All right. So we are going to talk about anti-hypertensive drugs today. Am I audible? All of you? Okay. So first of all, what we need to know is what do you mean by the word hypertension? Hypertension means in simple language, high BP, blood pressure is যেটা correct, exactly, that is called as hypertension. So hypertension is basically high blood pressure. So hypertension or high blood pressure is actually nowadays very common. It's a common cardiovascular condition where your BP will always remain elevated like that. So as far as the drugs are concerned, if here we are not going to talk about more of high BP or the physiology of BP, but we will more of talk about the pharmacological aspect of it. And as far as the actual thing is concerned, what is this high BP and all, that we are going to discuss later on in medicine. So as far as antihypertensive drugs are concerned, so you see, these are the basic classification of the drugs. So one way of understanding the treatment is you are going to use diuretics. So diuretics, when you are using, we haven't discussed yet, but there will be certain drugs like loop diuretics. Okay, do you understand a little bit of nephron? Do you know a little? Do you have any a little idea about nephron? Acha. So, do you know that what is a sodium potassium 2 chloride co-transporter? Acha. See, okay. So let me focus on that. So let me bring the screen here. Now, I hope you can see the screen, isn't it? Acha. So basically, I'm going to draw. It's very simple, not a big deal. I'm going to simply draw a structure of a nephron. So in a nephron, you're going to see that there is present this as the Bowman's capsule. Now this Bowman's capsule is going to become. It is going to show some convolution. Am I audible? So, could you hear what was like, or I was disconnected or something? তার আগে কতটা শুনেছি? How much could you hear? নেফ্রনের পরে you couldn't hear anything? Can you hear me now?
Yes, sir.
Acha, okay, I think there is a little bit of power snap. Okay, I'll just repeat what I said, okay? I'll just repeat. So let me get back to the original condition. So I was telling that this is our nephron, and in this nephron we have something called as the Bowman's capsule. Bowman's capsule continues to form the proximal convolutions. Now those proximal convolutions are going to continue to form the descending limb. Descending limb gradually forms the Henle's loop. Then it converts into the thin segment of ascending limb, then the thick segment of ascending limb, and then the distal convolutions. And that's it about the nephron. But as far as the concept goes, so later on it is also going to connect with the collecting duct. So this concept everybody knows.
Yes, sir.
Acha.
Yes, sir.
So at the thick segment of ascending limb of Henle's loop, you will notice that there are present some of these proteins. Some special proteins are present in the thick segment. Okay. Now, what is the job of this protein? The job of this protein is to throw out a sodium ion, a potassium ion, and two chloride ions. Okay, so its job is to throw out a sodium ion, its job is to throw out a potassium ion, and to throw out two chloride ions. This is the job. Understood? So what happens over here is that if these are throwing out this sodium, potassium, and all, if these are throwing out the ions, so can you tell me whether the concentration of the filtrate inside the tubule, okay, where I have put the question mark, the concentration of the filtrate inside the tubule, that is increasing or that is decreasing? Is it getting concentrated or is it getting diluted?
Diluted, sir.
Correct. So we can say that the thick segment of ascending limb of Henle's loop is a diluting segment because it is diluting everything.
Yes, sir.
Correct. So you see that here now if I have okay, another thing is that because of these ions, what is the benefit? Because of these ions, the benefit is from the in this area, I can say suppose this area, the dotted area here, what is happening to the concentration? The concentration should increase, decrease, or remain same in the interstitium. Look at the medullary interstitial area that I am talking about.
Sir, portion by increase concentration.
Correct. So if the concentration increases over here, do you realize one thing, that from the descending limb there will be reabsorption of water?
Yes, sir.
Correct.
Yes, sir.
So if there is reabsorption of water taking place, that means there, like your bloodstream will be getting more water. Your body is actually absorbing more water. It means
body থেকে absorb হবে তো water.
so that means blood volume will be increasing and blood pressure will be increasing, and hence blood pressure will be
increase
of course increasing. So imagine you have got a drug, and that drug is going to work on these Sodium potassium chloride co-transporter. Can we check the blood pressure? Can we reduce the blood pressure?
হ্যাঁ স্যার করতে পারবো।
Correct. Bus, this is what I'm talking about. This is what diuretics do. Diuretics inhibit the, these are called as loop diuretics. So what they will do is they will not allow water reabsorption. Diuresis, what do you mean by the word diuresis? Diuresis mane, always remember, loss of water. Okay, diuresis mane there is always loss of water. Okay, so
হ্যাঁ স্যার
if salt is not thrown out, if salt is not pumped out, then the water will not be reabsorbed. If water is not reabsorbed, then this water will come out through the urine. So that's what is diuresis. And who is doing it? It is the loop diuretics. So these are loop diuretics, so they help in not only hypertension. Suppose your body is swollen, can I use it over there? If your body is swollen, edema.
হ্যাঁ স্যার তাহলে তো জলটা বেরিয়ে যাবে।
Exactly. So anyway, we are going to discuss this thing. Then comes up another thing, that is like thiazides. Okay, so even thiazides are also going to work. Thiazide diuretics are also another kind of diuretics. Okay, thiazide diuretics, loop diuretics, all these diuretics are there. Okay, so you see this is okay, I'll remove this part. Okay, so oops, do you realize the diuretics now? Understood diuretics? What is diuretics? Drugs used in hypertension.
হ্যাঁ স্যার
Acha. Next comes up the sympathoplegics blockers, or basically in simple language, alpha blockers, or beta blockers, like that. So these kind of drugs can also be there. Okay, the beta blockers primarily, we will talk about beta blockers over here. So you remember beta adrenergic blocker? What was beta adrenergic blocker doing? It was actually increasing. If you stimulate beta, you remember where was beta receptors present? Where was beta receptors present? Who remembers? We have discussed this in previous classes.
স্যার হার্ট কিডনি
Heart, yes, kidney. So we talk about heart. So if beta is stimulated, then myocardial contractility will be
স্যার
increase korche. Now if we are going to block this beta, so if it is a beta blocker, if you are going to block this beta, that means heart rate and contractility should
চেঞ্জ হওয়ার কথা নয় বা কমে যাবে।
কি হওয়ার কথা না, what কি
চেঞ্জ হওয়ার তো কথা নয়, মানে বিটা তো ইনক্রিজ করে, মানে
হ্যাঁ, তো ইউ আর ব্লকিং বিটা ব্লকার না,
তাহলে ডিক্রিজ করবে মানে।
হ্যাঁ, তো টেল দ্যাট, সো দ্যাট ইজ হোয়াট আই এম আস্কিং, দ্যাট ইট উইল রিডিউস দ্য হার্ট রেট অ্যান্ড কন্ট্রাক্টিলিটি.
হ্যাঁ স্যার
So understood how the sympathoplegics they are going to work?
হ্যাঁ স্যার
Acha. Then there is something vasodilator. So if you look at it, there is something called as calcium channel blocker. Okay, we will discuss about calcium channel blocker. Like if calcium channel is blocked, then there will be calcium influx or calcium efflux.
স্যার ক্যালসিয়াম তো বাইরে থেকে ঢুকছে, তাহলে ব্লক করলে তো মানে ইফ্লাক্স হওয়ার কথা।
ব্লক করলে কি হওয়ার কথা?
ইফ্লাক্স হওয়ার কথা
না, efflux কেন হবে? যদি if you are like, see, what is the job of calcium channel?
ক্যালসিয়াম ভিতরে আনা,
And if you block it,
বাইরে যাবে, মানে কাজ মানে ভিতরে ঢুকবে না আর কি।
হ্যাঁ, তো
তাই স্যার
okay, so like today you are giving bizarre answer. So actually what is happening ki if there is blockage of the calcium channel, then what you are going to see is that the calcium channel is blocked, no calcium is entering and no contraction is taking place. I mean less contraction is taking place. So are you understanding how we are trying to cure your hypertension?
হ্যাঁ স্যার
Then you see there is next thing, angiotensin antagonist. So there are two things. One is a angiotensin receptor blocker and another one is ACE, Do you remember this thing? What is ACE? What is this receptor?
স্যার ওটা তো
Angiotensin.
কনভার্টিং এনজাইম একটা,
হ্যাঁ
আর রিসেপ্টর ব্লকারটা তো ওই কি বলে ইয়ের ওখানে কিডনির ওখানে, না না ভুলে যাচ্ছি রিসেপ্টরটা কোথায় ছিল। তো ওইটাই রিসেপ্টরে তো অ্যাঞ্জিওটেনসিন 2 গিয়ে বাইন্ড করে, ওখানে গিয়েই তো তার কি বলে ব্লাড প্রেশারটা ইনক্রিজ হয়।
Okay, and what is the job of angiotensin converting enzyme?
স্যার ওটা অ্যাঞ্জিওটেনসিনোজেনকে অ্যাঞ্জিওটেনসিন 1 এ কনভার্ট করছে।
So angiotensin converting enzyme is secreted from.
স্যার ওটা বলে লাংস।
Very good. So basically, rest of the people, are you understanding what our Dr. Obirup is talking about? That is basically RAS pathway, renin, angiotensin, aldosterone pathway. So when is usually renin secreted? Renin is secreted when the BP goes
স্যার লো হয়ে যায়।
low, correct. So when BP goes low, your renin will get immediately activated, RAS pathway. So when there is RAS pathway activated, your BP starts increasing higher. Now the question is this: ki if the BP goes very high, that means that's what we are going to treat here. That is what we are trying to correct here. So if the BP, if you want to slow down the BP, lower down the BP, so you have to block the RAS pathway. है ना?
হ্যাঁ স্যার।
So we are going to block the we are going to block the angiotensin converting enzyme. If you block angiotensin converting enzyme, then you will see that BP is not getting high, RAS is getting blocked. If you don't allow angiotensin 2 to work, then you will see that again RAS pathway is getting inhibited. Okay, so you will see all these things. Am I getting clear?
হ্যাঁ স্যার। স্যার বলছি বেশিরভাগ পেশেন্টরাই তো মানে ওই লো সার্টারের মেডিসিনগুলোই খায়, মানে বলছি অ্যাঞ্জিওটেনসিনোজেনের জন্যই কি ম্যাক্সিমাম হাই ব্লাড প্রেশার হয়?
Definitely no. So that's what we will be discussing here.
তাহলে স্যার ম্যাক্সিমাম লোককেই দেখেছি ওই লো সার্টান মানে টেলমিসার্টান ওইগুলো খায়।
That is a part of the medicine. Okay, that is like we won't be able to discuss today, but I'll give you an idea how do we treat it. So there is a step-by-step protocol how we start it. The American Heart Association has got a proper guideline, okay, on how to deal with all these things. So we'll see to that. It's not like that. A lot of people they practice in that way, but that is not the way. But anyways, so first you understand how are we dealing with it. First you understand what are the varieties that we have, then it will be easier for you to understand the rest. Okay, so moving on. So let's talk about there is something called as a renin inhibitor also. Okay, but regarding this we won't be discussing much. This is like something very uncommon latest. So that is a renin inhibitor. So basically again the same thing, like we are actually inhibiting the RAS pathway. Clear everyone? Understood?
Yes sir. Yes sir.
So you see, this is the thing that I was talking about. So first of all, you look at the thing called as diuretics. So do you see thiazide written over there? So thiazide is working. So in DCT, if you look over here, so you will see that in DCT there is present something called as thiazide.
Yes sir.
So in DCT there is a sodium chloride co-transporter present, so it is going to block that co-transporter. And this is what we discussed. See, loop diuretics, look at the location that I was talking about. You will see that it is the same location. You see, it is the same location.
Yes sir.
All right. So and after that, if you look at this beta blocker, you can check out the beta blocker and see what is it doing. Beta blockers, okay. Beta blocker understood or not? See,
স্যার একবার দেখছি, একটুখানি দেখছি।
okay. whatever I taught you just now, just you can look over here.
স্যার ব্র্যাডিকাইনিনের ওই পোর্শনটা কভার করবেন।
See all of them.
স্যার বলছি ব্র্যাডিকাইনিনের পোর্শনটা একটু বলবেন এসি ইনহিবিটরসের জায়গায়।
হ্যাঁ, so first of all, what is the idea that you have about bradykinin? What do you know? What do you think bradykinin is?
স্যার ব্র্যাডিয়ারিথমিয়া করে বা ওরকম কিছু।
Okay, rest anyone else has got any idea about bradykinin?
না স্যার।
See, bradykinin is basically a chemical messenger. Okay, so bradykinin is just like, you know, you have interleukin, you have pyrogens, fever causing agents. Similarly, you have bradykinin. Bradykinin, I thought you should be knowing, because if you have studied inflammation in pathology, you should be knowing about bradykinin. But anyways,
প্যাথোলজিতে ইনফরমেশনে ছিল।
so bradykinin causes blood vessels to relax. Okay, so basically if there is too much bradykinin, then there is going to be hypotension. So if like this bradykinin, it mediates and modulates that RAS pathway, so because that's its job. So if you are using ACE inhibitor, see where is ACE inhibitor working? It is not allowing conversion of angiotensin 1 to angiotensin 2, number 1. Number 2 is it is not allowing bradykinin over there. Okay,
স্যার ব্র্যাডিকাইনিন রিল্যাক্স করে আর কি।
হ্যাঁ, bradykinin normally it causes hypotension, vasodilation.
হ্যাঁ
And-
এবার বুঝেছি।
হ্যাঁ।
এসি ওটাকে ইনঅ্যাক্টিভ করছিল।
হ্যাঁ, ACE inactivates bradykinin, and ACE inhibitor is going to inactivate ACE.
হ্যাঁ স্যার।
So bradykinin is not getting inhibited, mane now it is going towards hypotension. Rest of the people understood?
হ্যাঁ স্যার।
All right, check out rest of the photo.
স্যার ইএনএসি অ্যান্টাগনিস্ট।
Which one?
স্যার ইএনএসি অ্যান্টাগনিস্ট।
So like that you can ignore, that I have kept over here. That is basically the sodium channel.
স্যার স্যার এমআরআইটা।
Acha, see, okay, then first of all look at it. If we say ENSE, then like you actually don't need it so much detail, but okay, fine, since we are discussing, you see ENSE, what is the full form of it? It is epithelial sodium channel. Okay, it is epithelial sodium channel, which is responsible for sodium reabsorption from the distal part of the tubule. Okay, from the distal tubule, sodium is reabsorbed through this epithelial sodium channel. Understood? So if sodium is reabsorbed, do you understand that even water will be reabsorbed?
হ্যাঁ স্যার।
So if water is reabsorbed, then blood volume will be
ইনক্রিজ করছে।
increase korche and blood pressure is increase korche.
হ্যাঁ স্যার।
So now if you are using ENSE antagonist, then what do you think? So it will get blocked, and if it gets blocked, then sodium is not reabsorbed, water is not reabsorbed, so your blood volume is not increasing.
স্যার তাহলে তো সোডিয়াম পটাশিয়াম লেভেল মানে সোডিয়ামের লেভেলটা ফল করে যাওয়ার মানে সম্ভাবনা থাকবে।
So that to definitely, so that is a different issue. Again, medicine. You have to also check the, the blood ions which are present.
হ্যাঁ স্যার। ওকে স্যার।
Okay, rest of the people, you check it out, see whether you understand it or not. And as far as MRA is concerned, MRA, since we are discussing, let me tell you, MRA is basically mineralocorticoid. MRA stands for mineralocorticoid receptor antagonist. Understood? Mineralocorticoid receptor antagonist.
ওকে স্যার, বুঝেছি। মানে মিনারেলোকর্টিকয়েডও আর কি মানে ব্লাড ভলিউম বা ব্লাড প্রেশার বাড়াতে হেল্প করে, মানে ওয়াটার অ্যাবসর্পশন।
হ্যাঁ।
ওকে স্যার।
So mineralocorticoid, see, what is, can you name one mineralocorticoid?
স্যার কর্টিসল।
Mineralocorticoid example is aldosterone. Cortisol is a glucocorticoid.
ও হ্যাঁ হ্যাঁ।
These are all basics. What is this? Oh, hai.
বুঝে গেছিলাম।
So understood this thing.
হ্যাঁ স্যার।
Diuretics, how is it working? ACE, how it is working? ARB, angiotensin receptor blockers, beta blockers, calcium channel blockers. Understood, everyone?
হ্যাঁ স্যার।
Acha. So you see, this is also another very commonly used drug, just like you said that losartan, telmisartan people use. People also use a lot of amlo. Okay, so if we look at this clinical indications, so definitely for high BP we can use to treat it. Okay, but even in, we can, some of them they can be used for treatment of heart failure. I'll teach you heart failure later on, as well as post MI, myocardial infarction. Do you know myocardial infarction? We discussed it, I think.
হ্যাঁ স্যার, ওই তো ইনফার্ক্ট মানে টিস্যু ড্যামেজ।
Correct. Now, as far as the side effects are concerned, so you see, the thing that you are pointing out, that came out to be true. See, electrolyte imbalance can happen, hypotension can happen, even renal dysfunction can also happen. Understood?
হ্যাঁ স্যার।
Okay. So now the next thing that we talk about, let's do some case study so that the concept becomes clearer to you. So here is the patient. Look at the details. So patient name is Mr. John Smith, 55 years of age, male, no such significant medical history. Father had a high BP case, sedentary lifestyle, BMI 30, no regular exercise, diet is high sodium diet. Now patient comes up to you complaining of simply headache and dizziness. Now when you check the BP, you find the systolic blood pressure to be 160 and diastolic blood pressure to be 100 millimeters of mercury, heart rate clocking at 80 beats per minute, and nothing specific in the physical examination. Now you went for a lipid profile test, you went for a blood electrolyte, you went for the kidney function test. All came out to be normal. So the only finding that we have right now, that is only this thing, that high BP, है ना?
হ্যাঁ স্যার।
Okay. So assessment is uncontrolled hypertension we can consider. So you tell me now what
বিটা ব্লকার্স,
কি হবে?
বিটা ব্লকার্স দিলে কেমন হবে স্যার? হার্ট রেটটাও তো বেশি আছে।
Beta blocker, okay, fine. And what else?
ইলেকট্রোলাইট স্পাইকস তো নরমাল আছে। তাহলে স্যার রিনাল ফাংশন নরমাল থাকলে তো দেওয়ার দরকার পড়বে না, মানে সার্টানস গুলো।
अच्छा,
না সার্টান দেয়া যেতে পারে, রিনাল প্রবলেম হলে তো সার্টান দেয় না। এটা থেকে একটু ইয়ে হচ্ছে আমার মনে হচ্ছে শুধু বিটা ব্লকার।
Okay, everybody take 2 minutes time. Think on it. Don't need to speak. Okay, how to blabbering will not help. Just take 2 minutes time. Think on it. Let everybody think also, and then we will start discussing logically.
স্যার আমি একবার বলবো।
Okay, have you made up your mind?
হ্যাঁ স্যার মোটামুটি তো মনে হচ্ছে, বুঝতে পেরেছি একটু একটু।
Rest of the people?
হ্যাঁ স্যার, মানে মনে তো হচ্ছে বা জানি না।
Okay, so first thing is tell me, acha chalo tell me. First tell me how do you want to start with the treatment?
স্যার ফার্স্টে হাই সোডিয়াম ডায়েট দেখতে পাচ্ছি আর ফাদার হ্যাড হাইপারটেনশন দেখতে পাচ্ছি। ওই দুটো আমার মেন পয়েন্ট মনে হচ্ছে। হাই সোডিয়াম ডায়েট হলে কি মানে সোডিয়াম রিঅ্যাবজর্পশনটাও বেশি হবে, তাহলে ওয়াটার রিঅ্যাবজর্পশন ওখান থেকে হচ্ছে। সো সোডিয়াম চ্যানেল অ্যান্টাগনিস্ট দিলে হয়তো প্রেশারটা কমবে, ফার্স্ট আমি এটা বলছি।
Okay.
আর ফাদারের হাইপারটেনশন আছে, সো ওরকম জিনগত হতে পারে, তো অ্যালডোস্টেরন সিক্রিশন বেশি হতে পারে, তো লোসার্টান দেওয়াই যেতে পারে।
Okay.
এই দুটো আমার মনে হলো।
Acha. All right. Any other idea? Anyone else?
স্যার ওই হাই সোডিয়াম ডায়েট যেটা আছে ওটা দেখে ওই আমার মনে হচ্ছে যে আপনার ডাইডিউরেটিক্স দেওয়া যেতে পারে, স্পেশালি থায়াজাইড যেটা আছে ওটা।
আচ্ছা,
আর
কেন why thiazide?
বিকজ স্যার এটা সোডিয়াম অ্যাবজর্পশন কি ইনহিবিট করছে, প্লাস ব্লাড ভলিউম রিডাকশনটার সঙ্গে একটা মানে কি বলবো ডাইরেক্ট কানেকশন আছে এটা, মানে রাদার দ্যান লুপ ডাইউরেটিক্স।
আচ্ছা, ওকে।
ওই জন্য লুপ ডাইউরেটিক্স এর থেকেও আমি থায়াজাইড থেকে বেশি প্রেফার করবো এই ক্ষেত্রে।
ওকে।
আর নেক্সট স্যার যেহেতু হার্ট রেটটা হাই আছে এখানে, সো ওটা দেখে আমার আমার মনে হচ্ছে, আই এম নট শিওর, বিটা ব্লকারটা স্যার হলেও হতে পারে।
ওকে।
এই জায়গাটা একটু কনফিউশন হচ্ছে।
আচ্ছা, আচ্ছা, and what else we have got? Even Dr. Devoshmita here as well. What is your takeaway?
স্যার আমার একটা পয়েন্ট, অভিরূপ যেটা বললো যে ফাদারের আছে, তো এখানে অ্যালডোস্টেরনের, তো ওখানে অ্যালডোস্টেরনের ব্যাপার হতে পারে। আর তো স্যার মানে আর সেরম মানে আর বাকি তো ওরা বলেই দিল যে সোডিয়ামের ডায়েট, হাই সোডিয়াম ডায়েট, তো মোর অর লেস ওইগুলোই মনে হচ্ছে। কিন্তু স্যার বিটা ব্লকারটা নিয়ে আমারও সেরকম কনফিউশন আছে, সৌমিলি যেটা বললো।
আর
Okay,
রেগুলার এক্সারসাইজ করাটাও দরকার, ওটাও
okay, okay. Very good. So if you all together combined appear for such kind of clinical examination, I think you will do some good job. But alone it will be little bit difficult as of now. Lol. Okay, so jokes apart, let's see. So good part of the story is whatever you said, almost it is right. So start with the basics. First thing that you will do, you will try to do some lifestyle modification. We are going to do some dietary changes, and we are going to advise low sodium diet, of course. Okay, you got it very right. So we have to ask for low sodium diet. Okay, that is very very important. And of course you should ask the person to go for green leafy vegetables, fruits and all. And also remember, the person had a sedentary life. Did you check? The person had a sedentary life.
হ্যাঁ স্যার, চেক করেছি ওটা।
If the person had a sedentary life, don't you think that you should also advise the person to go for weight reduction?
হ্যাঁ স্যার, ওটা বলছিলাম, রেগুলার এক্সারসাইজ।
হ্যাঁ স্যার।
So the person should also go for weight reduction as well. Okay?
স্যার এটা যদি পেশেন্টকে বলি, পেশেন্ট মারবে টারবে না তো?
না,
ওটাই ভয় লাগে।
no, because see, if this is necessary, then you have to tell it. You have to do your job, because anything happens, whenever you will stand in the front of the judicial system, you have to defend yourself. You have to defend your own self. That's more important. Okay, so this is not a big deal. Even I also keep telling patients for various reasons that you have to reduce the weight. Sometimes there is a huge amount of buccal pad of fat present, and it becomes very difficult to examine. And at that time, even I have to ask the patient that okay, what is your this thing, what is your weight? And when I see the weight is high, so I ask the patient that you have to reduce the weight. Okay, so it's very common thing. You have to do that. If it whatever it takes to treat the patient, you have to do that. Okay.
হ্যাঁ স্যার।
All right. And after that, next thing is you have to ask the patient, since sedentary lifestyle, so you should also ask the patient to go for a exercise, physical activity. How much physical activity is needed? 30 minutes. Okay, remember this. At least 30 minutes will be required. Okay.
স্পেসিফিক ক্যালোরিজ বা কিছু বার্ন করা ওরকম কিছু আছে?
Specific calories right now, to since calorie ache definitely, but here to nothing is mentioned na related to the calorie.
ওকে স্যার, তাহলে ঠিক আছে।
Now, what is most important and that you have to know, that is for BP, one important factor is stress. Okay, so there will be stress management techniques should be taught to the patient, and if the stress is managed properly, then you will see that there is definitely some benefit in the BP, because stress increases blood pressure. Okay.
ওকে স্যার।
Now, so this is some basic things. Now coming to the treatment, drugs part. So first thing is, well said, high sodium content was there in the diet. So definitely you should first think about thiazide diuretics, like hydrochlorothiazide. Okay, we will be discussing it later on. So hydrochlorothiazide, we will start with low dose, and just like both Shomili and Devasmita said, we have to start with the hydrochlorothiazide, and like Obirup said, we also have to keep checking, we also have to keep monitoring the electrolytes and also the kidney function. Now imagine that you were considering about the ACE inhibitor. When should we use ACE inhibitor? I think Obirup was talking about the losartan, है ना?
হ্যাঁ স্যার।
See, if Mr. Smith was having something like diabetes, was having something like proteinuria, then you should consider all these things. Okay, if you don't see any case of diabetes, then why will you go for it? If you see that there is proteinuria, protein is getting lost from the kidney, then you can go for like ACE inhibitor, or you should start modulating the RAS pathway. Otherwise, why will you start modulating the RAS pathway? Next comes up
রাসের সঙ্গে প্রোটিন বেরোনোর কি আছে, মানে প্রোটিনিউরিয়া?
Mane, if there is proteinuria happening, that means maybe the glomerular filtration is excessive, maybe due to the high BP the kidney is getting damaged. So we have to do some control on the afferent arteriole, glomerular feedback, JGA, juxtaglomerular apparatus. You remember the feedback mechanism, glomerular feedback. So we have to modulate that area, na? Otherwise the kidney will get more damaged.
Okay sir.
Then we have to think about ACE inhibitor or ARBs. Okay, then we will think about it. Coming to beta blocker. So one good example of beta blocker here is atenolol. Okay, so if you see that why should we use beta blocker? Now if you see that in this patient, along with high BP, the patient is having some other cardiovascular condition. Other cardiovascular condition bole to you see that there is angina pectoris or something like that. Then you can go for it. Okay, then you should go for a beta blocker.
Okay sir.
Acha, another thing here I want you to know. If other drugs are not very effective or not well tolerated, then you can add calcium channel blockers also. Okay, if you see that the other drugs are not getting well tolerated. Understood or not?
Yes sir.
Correct. So clear with the idea? And after that, of course, you should monitor. You should adjust the dose. If needed, you can add some medications to achieve your whatever your target is. Okay, so you should do all this stuff. Everybody understood or not?
Yes sir.
Acha. And also you should also tell the patient education is very much mandatory here. So you have to tell the patient regarding how to do the lifestyle management and everything. You have to tell all these things to the patient. And after that, you should also ask the person. You should also tell the person about the complications. Like, if there is too much high BP, what is the problem with high BP? Suppose a person had high BP and the person dies. So what is the most common reason the person will die?
Infarction.
See, if high BP, why will high BP cause infarction? What has high BP to do with infarction?
স্যার ওটা মানে রেজিস্ট্যান্সের জন্য মানে কি বলবো?
No, a person is having simply high BP. So my question is, this person will die of what?
Stroke.
Yes. So risk of stroke, risk of kidney failure, these are going to be certain problems, and the person, you should treat the person, or you should teach the person that way. Okay, and you should, after every 4 to 6 weeks, you should, like, after every 1.5 month, so 4 to 6 weeks, you have to again repeat assess whatever happened, what is required or not. Understood or not? This is how you actually do some treatment. This is how you think. So well oriented thinking, I must say. But I think clarified about the beta blocker and the losartan, telmisartan, those things. So check it out once again, whether it is clear or not.
হ্যাঁ স্যার, ক্লিয়ার।
হ্যাঁ স্যার।
All right. Okay, everybody understood now? Pakka? Can I proceed ahead? Because we are done with
Yes,
this anti-hypertensives.